And since I have you on the podium right now, I'm actually going to pull one of the questions from the Q&A session because this is a question that comes up pretty commonly. So if oligoprogression is around 3 of your spots and those are treated with radiation, what if you get oligoprogression again, let's say a year later? Can you continue radiating those spots, or not? What's your limit? And that's a question to you. And the question to Dr. Marmarelis and Dr. Singh is, when do we switch systemic therapy, right? Oligoprogression, radiate, continue the same. Second oligoprogression, radiate, continue the same, or switch. How do those decisions are made?
So to answer your question, as radiation oncologists, we could keep radiating. And so it's technically feasible to continue to radiate. We don't have to use the same exact dose or total dose or dose per fraction, or number of fractions, but we can continue to administer meaningful tumoricidal doses or ablative doses of radiation. I think the bigger question is, should we do it? If I may just real quickly answer what I think about this, it's decision points. And so I've been thinking more about oligoprogression and progression beyond or treatment beyond progression a lot lately. And I've broken it down into decision points. And each imaging set that you get is a decision point for medical oncologists. Do we switch, not switch? So we looked back at our series of patients over 5-6 years at MSK, where each of them had either were treated with the ALK inhibitor, EGFR inhibitor, immunotherapy, and we looked at each decision point, and we tried to map out the burden of disease, the anatomic distribution of disease, and how or why medical oncologists decided to switch or not switch. But I will tell you that at least at this one academic institution, their instincts were spot on, because their decision points not to switch portended to better overall survival outcomes. And so it goes back to this idea that if you could keep patients on their first line of therapy longer, you usually are going to do better for those patients. And so, and by the way, number of METs is, I don't think any longer meaningful, because it's really about the velocity or trajectory of the disease. Because in the future, I have this prediction that a patient may come up to me with 10 METs, but if we can say that we can treat all 10 METs with local therapy, and then they'll have 2 years of a disease-free interval, we may go ahead and treat those 10 METs. And the opposite may be true, is that if we get a patient with 1 MET, and it should be a slam dunk to treat that 1 MET, but we know that on standard of care systemic therapy, they're going to have 15 more METs, then it's not relatively beneficial to treat that 1 MET. So I'm hoping that over time we go beyond the number of METs and just the trajectory as our means of decision analyses. And sorry for the long-winded answer, but I'll leave it to our medical oncology colleagues.
I like how you summarize that. I like how, one, you said these decision points for scans. That's a really big opportunity. We talk a lot about the scanxiety concept, right? Where patients are really nervous leading up to the scans, but so are medical oncologists. We're also worried too about, are we going to have that difficult conversation and lean in? Or are we going to be able to say, things look good, we can stay on the same therapy? So I like that idea of being able to continue on the same therapy as long as we can. That means we have more options to pull for the future, more options to sequence, and opportunities for clinical trials for patients. So that's a big priority of mine. What I highlight as well, too, is how quickly the time frequency between oligoprogression or development of new metastatic disease, how quickly is this happening, and how often is it happening, right? So if it's happening quickly, if it's happening often, yes, we can keep referring back to our radiation oncologist, but if that frequency is quite high or the time interval is quite low, then we maybe should be talking about considering a change in systemic therapy. And then it also depends on where the progression is happening, right? If it's in a precarious area, an area of high concern, we need to think about, if it's time to change systemic therapy. So that's sort of my general thought process.
Yeah, I think the only thing I'll add is, certainly it's a marathon in terms of trying to string together different therapies. And so if at all possible, I don't like to make 2 changes at once. And so if we're going to do radiation, I try to keep patients on the same systemic therapy. If we're thinking about radiation, but we want to change the systemic therapy, I'll actually make that change first and then wait and see if we still need to do radiation. So if possible, I like to make 1 change at a time.